Hi, welcome back to IU Radiology Case of the Day. My name is Tim Tsai, and I'm a fourth-year resident at the Indiana University School of Medicine. Today, we've got an interesting abdomen case. I'd like to give a shout-out and thanks to Dr. Hill for her help, and of course, Dr. Kuntz for organizing the entire Case of the Day initiative. All of the content in this presentation has been fully de-identified to protect patient privacy. Here, we have a 65-year-old woman with right upper quadrant pain. Here are the images. At the top left, we have an axial contrast-enhanced CT in the portal venous phase. At the top right, we have an axial T2 fat-saturated image. At the bottom left is an axial post-contrast image taken during the arterial phase. At the bottom right, we have images taken 5 minutes after contrast administration. Alright, now, what are the findings? What's your differential for this case? And what is your diagnosis? Let's go over the images. On this contrast-enhanced CT during the portal venous phase, we see a large rim-enhancing, heterogeneous, lobulated liver mass. There are also numerous satellite nodules, some of which demonstrate more of a peripheral rim of enhancement. On T2 imaging, the mass is T2 bright mainly along the periphery and does not appear to be centrally cystic or necrotic. This is the MRI image taken during the arterial phase of contrast, and again, we see that peripheral rim of enhancement. On the 5-minute delay, we see that the center of the masses have gradually increased enhancement. No washout lesions are seen. So this is a case of cholangiocarcinoma. Cholangiocarcinomas are the second most common primary liver malignancy and originate from the bile duct epithelium. The mean age of occurrence is at around 65 years of age, and higher rates are seen in Southeast Asia and in the Middle East. There are a number of risk factors, such as inflammatory causes including primary sclerosing cholangitis, bacterial, parasitic, or viral infections, or toxins, or alcohol. Ultimately, chronic biliary inflammation results in a higher risk of cholangiocarcinoma development. The only real chance of cure is surgical resection, which unfortunately nevertheless has a 5-year survival rate of around 15 to 40% due to tumor recurrence. There are a host of classification schemes, but a common theme is to describe the cholangiocarcinomas on its location and growth pattern. In terms of location, the tumor may be intrahepatic, perihilar, also known as a Klatskin tumor, or extrahepatic. Some lump the perihilar tumors into the intrahepatic subset, while surgically and clinically they are more similar to extrahepatic cholangiocarcinomas. A common classification system used for perihilar cholangiocarcinomas is the Bismuth-Corlett classification, which essentially asks which ducts are involved, such as the left or right hepatic duct, the common hepatic duct, or the common bile duct. In terms of growth pattern, they are described as either mass-forming, periductal infiltrating, or intraductal. I like to think about it as making a mass outside of the bile ducts, such as in this case, or it can be infiltrating within the walls of the bile ducts and appear more elongated, branching, and spiculated. Or it can grow into the duct lumen like a polyp, or fill the duct like a cast, or create a stricture. On top of that, the clinical presentation varies with the location of the tumor. A small intraductal tumor in the larger bile ducts, such as at the hilum, would be more clinically apparent at an earlier stage than a more peripherally located tumor, which would then allow it to grow to a larger size before detection, as in this unfortunate patient. Of course, combinations of growth patterns and varying extents of tumor location and involvement can occur. Mass-forming cholangiocarcinomas have similar findings across CT and MRI. The mass is homogeneously hypoattenuating with irregular lobular margins. There is rim enhancement with gradual centripetal enhancement, which may be reflective of the central fibrous stroma of the tumor. It can cause capsular retraction of the liver. Satellite nodules are also common. Pretty much all of these findings are in our presented case. Of course, as a malignancy of the bile ducts, there can be biliary ductal dilatation. There is a differential for each growth type of cholangiocarcinoma, but for mass-like cholangiocarcinoma, the differential would include hepatocellular carcinoma, metastasis, abscess, and tuberculosis. HCC is a more common primary liver malignancy, especially in cirrhosis, but combinations of HCC and cholangiocarcinoma may occur. HCC is pretty well characterized by its hypervascularity on arterial phase, followed by washout kinetics. HCC also commonly invades the portal veins, while cholangiocarcinomas should not. HCC should also not cause capsular retraction. Metastases can mimic cholangiocarcinoma. However, cholangiocarcinomas rarely have central necrosis with high T2 signal compared to metastatic lesions. This can be helpful in distinguishing the two. Abscesses have more central cystic change compared to cholangiocarcinoma. However, a phlegmon and immature abscess can be difficult to distinguish, so follow-up could then be helpful. Hepatic tuberculosis can appear targetoid with multiple layers, and this may be helpful to distinguish between the two. For more reading on cholangiocarcinomas and their other growth patterns, I'd highly recommend this paper. So in summary, cholangiocarcinomas are rather varied depending on its location and growth pattern. They're generally divided into intrahepatic, hilar, or extrahepatic for location, and growth patterns include mass forming, periductal infiltrating, and intraductal forms. This case was a mass-forming, intrahepatic cholangiocarcinoma and demonstrated characteristic features of irregular rim enhancement with delayed central enhancement, satellite nodules, and no central necrotic or cystic change. A common feature of cholangiocarcinomas is bile duct dilatation, of course. Differentiation from HCC can be tricky, and combinations of the two are known to occur. I'd be especially aware of periductal infiltrating and intraductal forms of cholangiocarcinoma, which would have more thickening and enhancement of the bile ducts, sometimes with a subtle intraductal mass. So as always, thanks for tuning in to IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz, and you can check out our complete collection of Case of the Day materials at the link below. Thanks so much, and have a great day.